name's Richard Loseby. I'm a UK-based emergency physician and intensive care doctor, and I've been working across both areas in my hospital in the northwest of England over the last couple of months, assessing and managing COVID patients. So I just wanted to sort of share a little bit of experience of the run-up and preparation, sort of in terms of our hospital response, our emergency department response, sort of from the hospital point of view. Just before we started seeing patients coming into the hospital itself, but we'd had positive cases in neighbouring areas, we set up a silver command structure, and this was basically run by the executive team, management team in the hospital, and we had daily briefings and clinical leads from each area of the hospital that attended that, reviewing latest test results, looking at the amount of positive cases that we were getting, and reviewing the bed states of the unit and the hospital. We ran a tabletop exercise in the early phase of the pandemic here, where we mapped out a patient journey from arrival to the hospital, through the emergency department, to the hospital wards, and through to the intensive care unit, and that involved representation from those various areas, hospital management and the infection control department. We very early decided to make a decision to stop all elective and non-cancer activity in the hospital. This enabled us to do a number of things. We were able to divide wards into cohort areas for suspected and confirmed cases, as well as non-COVID patients, and identify appropriate isolation areas in the hospital, and these tended to be wards that had separate cubicles. We were also able to expand our intensive care services by using operating theatres and theatre recovery areas, and we were able to redeploy staff to intensive care, emergency departments and medical wards, using staff that weren't being used to provide other services such as surgery. When we were redeploying those staff, we made a decision to protect those staff at higher risk, which were staff over the age of 65, those with comorbidities such as diabetes and heart disease. And then of vital importance, we met up with our oxygen engineers, and with an attempt to work out the quantity of oxygen we were going to need, and to work out how that was going to be delivered, and contingency planning for if we ran out. So then moving on to and focusing on our emergency department response, really we sort of had a focus early on staff safety and well-being, which meant getting the screening process right, and trying to educate staff on PPE. So the screening we did by using the case definition from PHE, which was based on WHO guidance, and we had a screening station at the front entrance to the hospital. We then split the department early into basically patients presenting with respiratory symptoms and those that didn't, and then patients were screened into either area. That's subsequently been adapted to red, amber and green. Green patients with no symptoms, amber being suspected cases, and red being patients that are going to have aerosol generating procedures done on them, and the PPE for those is slightly different. We organise a daily briefing for staff, which covers updates from the government and regional networks. In the early phases, we organised PPE training sessions, including going through donning and doffing, highlighting the use of the buddy system, where another member of staff checks appropriate putting on and taking off of any PPE, and we put up signs in every cubicle to remind staff to wear PPE. I've got sort of examples that I could upload if people are interested. We increased the working hours of, and adapted pay appropriately for cleaning staff so that they were on hand operating continuously. And then we also split waiting areas for patients with social distancing, keeping seats 2 meters apart. Unfortunately, we made a decision based on government guidance not to allow family members to come in, but I'm not sure what the implications for that would be in Somaliland. Just to quickly mention about some clinical things, which we can go into a little bit more detail in the questioning. There are lots of useful materials from the African Federation of Emergency Medicine which I could share, but really we found that the only treatment that is useful for patients is oxygen. We also have some guidelines on the use of awake proning, where we lie patients on their front while they're receiving oxygen for sort of several hours at a time, because we've found that that improves their oxygen levels. I've also got sort of some instructions on how to do that if people would find that useful to share. We have developed sort of criteria based on local guidance, but there's also some guidance through the African Federation of Emergency Medicine on which patients need admission to hospital, which patients can go home. They tend to be the ones who have saturations above 94% with respiratory rates less than 20. They were able to be discharged home to self-isolate for a week. Just to finish off, from a regional point of view, when we were approaching peak, which for us was about 2 weeks ago, 3 weeks ago maybe, we started operating a gold command structure that was run centrally in the region, and that enabled us as a region to have oversight of activity in each sort of hospital and treatment centre, to know how many positive patients, what the intensive care bed use was like, and how many patients were needing oxygen. This allowed us to work across all the units in the region to provide mutual aid. So hospitals that were running short of PPE and equipment were able to share with each other. And it also enabled us to transfer some patients to other facilities when we were operating at capacity. Also, all private hospital activity in the region was stopped to allow extra capacity should it be required. And I'll leave it there.
Good morning, everyone. My name's Ahmed. So I'm a respiratory physician and general medicine, and I've primarily been working on the medical wards, looking after COVID-19 patients with some input in critical care. Thank you, Richard, for that excellent presentation. I think that covers the strategic response at local hospitals and also regional level, and it's quite similar to the planning and also response as the situation changed, or as we approached the peak in our hospital as well. In terms of the clinical management, I think actually on the medical wards, those patients that needed admission, the care is largely supportive. As Richard has already said, it's providing oxygen and supporting them as best you can. So I think the burden of responsibility, certainly here in the UK, has fallen on critical care, where the sickest patients are transferred to. Um, on the medical wards, I would say probably nursing care has been the most important, because it's the nurses that are looking after these patients once we have seen them and performed our ward rounds and made the medical plans. So I think that nursing care is really, really important, particularly patients requiring oxygen and regular observation, which is more challenging when you have to wear personal protective equipment and maintain strict infection control. Not only that, of course, health workers are also at risk of becoming unwell, so staffing can be an issue. So you may well have less staff to do the same amount of work or a greater volume of work as more patients come through the door. I guess I just wanted to share three reflections, really, or perhaps two, that I think I found pretty important and also quite challenging here in the UK. I think the infection control measures that Richard has spoken about, particularly creating pathways for your suspected cases, your confirmed cases, and your presumed non-COVID cases, is really, really important. And that's not been the easiest, certainly at my hospital, to create those areas within the hospital. But I think from my perspective, certainly to protect patients and also to protect staff, I think that's one thing that uh, if you are planning for that within your hospitals, then I would say that's something that is really important to think about how you're going to do that. I think the second thing is, what about those patients who are unwell but are not able to, uh, or are or have a number of medical comorbidities or issues that actually intensive care is probably not appropriate? How do we manage those patients when the medical therapy that we're able to offer on the wards may not be enough? So palliative care has been really important, actually, here. Our ability to keep patients comfortable, pain-free, and not in distress. And how have we been able to do that? Particularly with shortages in some of the equipment that's needed. But I think that has been invaluable, really, because it's quite difficult to see these patients suffering and not being able to do very much about it, apart from trying to keep them comfortable and pain-free. I think the third thing is really the difficulty for patients in hospital not being able to see their families in person because of the infection control measures. I think that's been quite difficult. I think we've been able to use smartphone technology and iPads and things to maintain that level of contact, but I think that's also been quite difficult, and it's quite hard. Of course, most people seek solace from their families and that support, and with your family being next to you is very different than being on the end of a smartphone. So I think in how do we try and facilitate that contact and that support? And then finally, I think, is just the support for each other as health workers. I think that's really, really important. Being there when perhaps people are unwell and you have less staff and more patients coming through the door, we've had to rely on each other coming together across specialties, nurses and doctors working together. I think that's been really important. I think I'll leave it there.
So my name's Natasha Trenchard-Turner and I'm matron in St George's Hospital in South London. So in terms of the kind of response that I've been involved with is we have a critical care outreach team here, which is basically a critical care team of doctors and nurses that work outside of the critical care, assessing patients and seeing who needs to come to critical care and how we can optimise them on the wards and in the ED department. So a large amount of my work has been about prepping my staff and thinking about how COVID-19 would affect our response to patients, because initially one of the things we were very concerned about was having kind of a green side to the team and a red side to the team, so that we didn't have our staff visiting COVID patients and then going and seeing non-COVID patients and possibly infecting other members of like the hospital population. And so in terms of our response, I've just been auditing it, and at the busiest points, Georgia's had about 308 patients who had tested positive who were inpatients in the hospital, and over 70 critical care patients who had tested positive. So out of that group of 300, over a kind of like a month's period, my team saw over 100 patients and assessed them and decided whether or not they needed to go into intensive care or not, and also tried to optimise them on the ward. And so I'm going to have more details from that audit because I'm currently going through the information, and I'll be able to send that on to you and share that with you. We're really happy to share information, because I think what's kind of interesting for you to know is about how many of these patients in the cohort kind of become critically ill and require further support, or if you weren't able to provide that, as has already been discussed, might need palliative care. And it is quite a high proportion of these patients. And so of the 100 that we saw, we took over 60 of them into ICU. And of the 100 that we saw, about 45% of them so far have gone home. And we've got quite a high mortality rate. And I also think it's interesting looking at our data that we are in agreement with a lot of what other people have found, which is that hypertension, diabetes and asthma are risk factors. Definitely being obese we've found is a large risk factor, and again I'll be able to send you the details from my audit. And also in our group of patients in London, we found really that being over 50 rather than being over 65 has been an issue in terms of people that we would take into intensive care, usually who have become extremely critically unwell. I was also part of the team that addressed the overall response within St George's and liaised with the other hospitals in London, but I think that's been quite well covered already. And also I've worked shifts in the intensive care and also taken part in retrievals. So one of the systems that we've had in London is we've been trying to cohort the patients within larger intensive care. So my hospital is a tertiary referral hospital, and so we've been going out and picking those patients up and bringing them to us. And one of the things that we've found is that they don't tolerate being moved much. So if you have a system of kind of taking patients that might be sicker from more rural areas into larger areas, really how they behave on transfer is they get extremely unstable from being transferred, and it can take hours to kind of stabilise them afterwards. The other issues that I think are really interesting is there was a lot of talk in the kind of literature about kind of in China and stuff, they weren't having to use very much renal replacement therapy, and we've found the opposite. We've had a large amount of renal insult from this disease, and we've been trying to examine that, like were we running people too dry and things like that. And we've also had a large number of sudden deaths in young people that we've put down to PEs. And then the other thing I'd really like to highlight is the psychological support for staff, because it's completely overwhelming. I mean, just things like trying to flip wards and into intensive cares in 24 hours in order to stay ahead of the number of beds that you need, even if it's planned. it doesn't always go kind of to plan. And additionally, the number of people that are dying and the pressure that puts on the staff has got very large psychological impact. I was also involved in the teams that have been planning for the teams and kind of organising how we were going to do it, the teams that go and intubate on the wards. But I know that this is not really something that there's a lot of resource for in Somaliland, but I'm happy to answer any questions at all about any of this. So.
Thank you, Natasha, and especially thank you for doing this from work. I know you're very busy, you've got a long day ahead of you.
Oh, it's no problem.
Yeah, okay. So, so Somaliland colleagues, you are not alone, and we have got a lot of experience here in the UK. We haven't always done things right, but we've got a lot of learning. So the rest of the session, we've got a good amount of time for your questions.
Since we have very limited resources of the personal protective equipment, I wanted to know, are they reusable? In which circumstances can we reuse the N95 and the PPE gowns?
So what we've been doing is wearing them, we call a session. So as in, we're going in and looking after a group of 6 patients for 6 hours, going out and having a break. And when we're finished having the break, we have to put on another set. So you change when you leave the care area. And so for my team that walk around the hospital, if we're going from one place to the next, we keep the same mask on because masks are a finite resource everywhere. So we've been keeping the N95 mask on for the entirety of us walking between all reviews of patients, and then when we stop to eat or have a break or whatever, then we'd take it off. With the gowns, again, if you're in one area, we've been wearing the same gown. However, we have the plastic pinny to go over the top, because the thing, we had a bit of an outbreak of Klebsiella in one of our ICUs, and there was concern that people were not actually changing their aprons and gloves between the patients. And so it's about kind of how you can clean them. In some hospitals, they're just cleaning the gloves with alcohol rub and then continuing between the patients, or between, say, doing one piece of care and another piece of care, when you would normally wash your hands. We have been taking our gloves off, washing our hands and putting fresh gloves on and a fresh pinny if we're changing between patients. But we have been leaving them for a session. What they've been saying to us from infection control advice is that if the mask is becoming damp, then it's no longer effective. So I think it's about people monitoring at that themselves, but it's definitely kind of a concern, but that's the advice we've been given, that's being supported by Public Health England.
Follow up on that, we sort of had guidance from Public Health England acknowledging that our PPE supplies are also sort of finite, and they recommended that we can wear a mask for the whole shift, as Natasha says, unless it gets soiled or wet or dirty. But we just, if we're sort of coming out of an area, then we have to remove it, fold it inside out, and they actually recommend sort of keeping it inside some sort of plastic cover. So that's what we would potentially do if we run short of N95 masks.
I think that's an excellent question, and I think we've been having some discussions in some of our other health partnerships where PPE is limited, and I think, certainly around what you do with your masks and how long you can keep them for. I know one of my colleagues has been doing quite a bit of work in gathering the evidence for that, and not just masks, but what you can do with gowns and how you can safely decontaminate with what solution. So if I can get the information that he's gathered, perhaps I can share that, or we can share that, Hannah.
Good. So I think Mariam's got her hand up. Mariam, would you like to ask your question?
Me, I'm Mariam Tahir. I need to know per patient how many skilled person can be can do the shift, as well as what equipment actually needed most, because sometimes people say ventilators and we don't have ventilator, but I really need more information about how we care the patient when he had when they had the severely ill, as well as what equipment, how we can, like now the cases died in Boroma hospital, and all the equipment is just closed in somewhere, isolated somewhere again, because actually we don't know how to disinfect and what is the disinfectant we have, that is it effective to kill the COVID-19. Thank you.
So in terms of disinfectant, again, I think that there's lots of kind of work being done, and we can send some kind of summaries of things. But in terms of what we do to infect our basic work, because obviously I'm doing a lot of work where we're taking patients from the wards to the ICU, so we're actually having to move equipment around, is we're using chlor wipes, so just kind of chlorine wipes, and we've been told that those are effective for equipment that's fragile or things that would like smear and stuff. The goggles and things, we're using alcohol, and then we've been told that this is effective enough. But I can send details of the actual wipes, so that we know what makeup is in those wipes. But what we have been trying to do is cohort equipment. So we have equipment that's for COVID patients, equipment that's for patients that we believe are negative, that have indicators that they possibly have COVID. In terms of what equipment that you need, I think one of the things that I know from being in Somaliland previously we're quite short of there is SpO2, so SATS monitoring, and that for me would be like a key thing, that if we could increase the amount of kind of access to SATS monitoring for the treatment areas, that would be really useful, because a lot of these patients present saying they don't feel that bad, they're talking to you in full sentences, usual things that indicate to you that somebody's in an acute respiratory failure are actually quite absent. Their respiratory rates can go up really high to like 50, but again, they're still talking to you and saying that they feel well. And so actually our key indicator of kind of how unwell they've become has been SATS monitoring. We have not been doing blood gases on these patients to preserve the blood gas syringes and equipment within ICU once they're sick. So wherever they're on the wards, it's very few patients that we've found that have actually had type 2 respiratory failure. So in terms of equipment, I would say SATS monitoring is key to looking after these patients, but other equipment is probably not so important. I'll see what the doctors think and whether or not they agree with me about that. And then your oxygen supplies, and that would kind of be my answer to that. In terms of staffing numbers, I think that's tough, because I know that families do a lot of the personal care in Somaliland, and if the families aren't able to come in and visit, you may have to increase your nursing numbers. So in terms of what we've been doing in the intensive care unit, we've had generally 3 members of staff, so 1 critical care nurse, 1 just registered nurse, and 1 healthcare assistant looking after 6 patients. In the wards, we've just had the normal ward nursing ratios, because a lot of the patients are just sitting there on oxygen and aren't too unwell. Let me know if there's anything else that I've missed.
Dr. Hassan is asking, like he's saying the regional hospitals does not have ventilators, but they have CPAP and BiPAP. So if since they don't have any access to ventilators, how can we use the CPAP in treating and supporting patients with COVID-19?
So in answer to Dr. Syed Mohammed's question about approach once the confirmed case of COVID, as Ahmed said before, it's supportive treatment really. So oxygen therapy, titrated to oxygen saturations. Make sure that they're hydrated, but not overly so. We tend to sort of make sure that the patients get fluid, but not large amounts. And the other thing is just maintain precautions in terms of appropriate PPE and be really adherent to hand hygiene before and after interaction with the patient. in answer to the CPAP and BiPAP. So I think experience internationally is different depending on where you work. Italy, I think, used quite a lot of CPAP. We've used a reasonable amount of CPAP, but I have to say patients haven't often tolerated it, because obviously it's quite a tight mask for a prolonged period of time, up to 6-7 days, and I've got to say we've not had a fantastic experience with CPAP, but we're currently entering a trial to compare standard oxygen with CPAP. And also high flow oxygen, but I don't know whether that's available in Somaliland. But I think the general consensus internationally is people don't really know the answer.
The comment I was going to make was about the risk kind of to the healthcare professionals of using CPAP or Optiflow, which I haven't ever seen in Somaliland. So the decision was made at St George's to actually not do those therapies outside of negative pressure rooms in the intensive care unit. So the Optiflow wasn't done at all outside of intensive care, and CPAP is done in like a cohorted area because there being such a high risk from the aerosols it generates to the staff. And so as Richard was saying, we've also found that it's not very effective, and a lot of the patients end up requiring intubation or are palliated. And so the kind of the risk versus the benefit, I think, is something that really needs to be discussed in these areas, because if it's not benefiting the patients hugely, but it's actually putting your staff at risk, is it worth doing?
We don't really know, and experience is quite varied. And I think you have to, even within London, you know, there is variation in practice. Our critical care or ITU department are quite pro CPAP actually, and they have been trialing all of the patients that are sort of severely unwell but not quite needing intubation and mechanical ventilation on a trial of CPAP with a face mask. I think there is a failure rate, and tolerance is an issue, but some patients have avoided the need for intubation. We've also been running a unit where we are delivering CPAP, but that's primarily been for patients who have stepped down either from mechanical ventilation or have done well on CPAP in the ITU department and have come to us. I think Natasha's very right about this being a high risk in terms of aerosol generating procedure, and I think you would need to make sure that your cohorting is adequate, but more important than that, the ventilation of where you're doing it, to make sure that you know that those aerosol the aerosolized droplets can disperse and not remain within the areas or the surrounding areas. So I think that's really important. And of course, adequate personal protective equipment. You know, you have to have those things in place, and your staff have to be safe. I think the other consideration really is that with CPAP, quite high flow rates are required to deliver it appropriately, and I think that's you know the supply that you have. I think you have to be full about. You know, certainly with us, as we scaled up the amount of CPAP, that affected the oxygen being delivered to the rest of the hospital. So I think, you know, the questions are: is it safe? And are you able to deliver it?
Yeah, I would completely agree. That was definitely one of our other kind of thought processes, was the amount of oxygen that it was going to eat up and why we've kind of ended up giving it or not. And I agree that we don't really have enough information, because it's about kind of how early you would do it for it to be effective. But then if you're doing it very early on a large group of patients, or on quite a lot of patients that maybe actually would have been able to just remain on oxygen, you're then using up your oxygen stores.
So my question is, with the limited resources we have in the country, especially oxygen and ventilators, how are you going to prioritize cases? For example, somebody come with COVID-19 with the age of 29 to 30 years, and somebody with over 70 years old.
Nora, thank you very much for your comments and question. I just want to sort of re-emphasize, I think in terms of therapy that's going to do the most good to the most people, it's got to be just standard oxygen, and I can't sort of emphasize enough how important we've found liaison with sort of our oxygen supply engineers in terms of getting that. I think these conversations about sort of potential rationing treatment are very, very complex and difficult. Our approach has been to sort of set up an ethical panel, if you like, of 2 or 3 senior clinicians and have discussions about sort of each patient individually, taking into account sort of their comorbidities, their general health, what the patient would want, and sort of discussion with their family. We've tried to sort of open up conversations to sort of a multidisciplinary team to make decisions about escalation of care.
Yeah, I think it's very, very difficult, you know, and I don't think there is a straightforward answer. But I think similarly here, I think in some ways we never got to a point where we had to make those types of decisions of someone not getting care or removing care for someone else, but there's of course plenty of decisions around who would benefit and from intensive care. But yes, I think it's about involving people in that discussion, so not taking the decision alone and factoring in things like comorbidities and the likely benefit of treatment. You know, if someone comes in who's critically unwell and perhaps you don't have a ventilator available, and you think they may well have comorbidities, then if the likelihood of survival is very low, then, you know, perhaps those are the patients where you think actually a palliative option would be more appropriate. So I would say it would be case by case, and involving people in that discussion.
And Richard and Ahmed, am I also right in thinking that there are some tools to assist decision making here? I think the African Federation of Emergency Medicine may have something. I'm sure I've seen others.
Yeah, so here we have the clinical frailty score, which we use as part of the decision making process. But sometimes it's also, yeah, so I think tools are helpful. I don't know whether the WHO have produced a specific tools with regards to this. I haven't seen them myself, but I'm sure there must be out there. But I think as well as tools, I think it's important to get your senior colleagues involved as well.
Yeah, I would agree, and I'd also, in terms of when we were talking about kind of staffing, kind of supporting our staff, so how they cope with these decisions. I think not having arbitrary numbers like saying, oh, people over this age, because that's the kind of thing that staff found very distressing when they feel like someone's been denied care that they think might have survived. So I actually think senior staff discussing comorbidities using things like frailty scores rather than having distinct groups that you will or won't treat is extremely helpful, and it really helps with people with coping, getting through this.
If you have questions that you've not been able to put or have answered, we're in connection, we're in contact with Dr. Manal. So if you share your questions with Dr. Manal, she'll put them back to us at the partnership. I just like to thank our presenters for taking the time to share their thoughts, and also to everybody in Somaliland who turned out.